Hello, everyone. Thank you for joining our webinar today on Principles of Recovery-Oriented Systems of Care. Larry Davidson from Yale will be leading this four-part series on the principles and practices of recovery-oriented care. I'll be turning things over to him shortly. But first, I'd like to review a few housekeeping items with you all. Please remember to mute your computer speakers if you're calling in via phone. The computer speakers can be muted through Adobe Connect by pressing on the green horn above the presenter's pod. Participant microphones will be muted throughout the webinar. During the presentation, if you have any technical difficulties or questions about the topic, you can use the chat and questions box down on the bottom left. This webinar is being recorded and will be available for viewing at a later time on the NE-MHTTC website. The PowerPoint slides and any additional resources discussed today will be posted on the website as well. Those attending today's live event will be eligible to request a certificate at the end of the series in February. More information regarding certificates will be sent in a post-webinar follow-up email. To reach us after the webinar, you can email newengland@mhtttcnetwork.org. Our NE-MHTTC mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. To ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. To learn more about us, you can visit our website. And with that, I will hand it off to Larry.
Thank you, Vanessa. Welcome to the webinar, everybody. I see we have people from all over the country, which is really terrific. As Vanessa mentioned, this is the first of a 4-part series, and today's discussion will focus on the principles of recovery-oriented systems of care. The notion of a recovery-oriented system of care has been around since around 2002. SAMHSA did a significant amount of work in trying to promote this vision till around 2012. And Vanessa did mention we'll be posting resources. One resource we'll be posting is a SAMHSA brochure packet on recovery-oriented systems of care that was published in 2011. From that, I'll just read you the definition so we're starting on the same page. SAMHSA defined a recovery-oriented system of care as encompassing a menu of individualized, person-centered, and strength-based services within a self-defined network. This menu includes clinical services and alternative therapies, as well as recovery support services. Recovery support services include peer recovery coaching and other forms of peer support, peer-run programs, recovery community centers, as well as employment, educational supports, social and family supports, case management, and housing supports. So it's a broad vision of all the treatment and support, rehabilitation and support that persons with serious mental health conditions or serious substance use disorders will need to enter into and sustain their long-term recovery. It's a wonderful definition. The difficulty is how you operationalize it. And as I said, this notion's been around now for almost 20 years, and there's still a lot of work to be done. So one thing we did, is developed an inventory of transformation characteristics for recovery-oriented system of care, which looks like this. I'm not going to expect you to read that, but there are many pages of this inventory, with this format. And what I want to do is walk through each of those domains. So I want to talk about how people receiving behavioral health services are viewed and treated by staff. And if there's one core component to recovery-oriented care, it's how people are treated and viewed by the staff who interact with them. But then I'll move to how people receiving behavioral health services are included in the design, delivery, and evaluation of care, which has been a much harder thing to accomplish. How care is planned, delivered, and improved on a continuous basis, and finally, how transformation is led and managed. So, and if you want the entire inventory after this webinar, it will be posted on the MHTTC website if you find it helpful. I've really found it to provide a useful roadmap to identify what are the relative strengths and weaknesses in the system of care, where are the areas where they need to work the hardest to improve, given that a lot of these things have yet to be accomplished by anyone in the country as far as I know. So let's start with how people receiving behavioral health services are viewed and treated by staff. The first item is people receiving behavioral health services are viewed and treated as unique individuals. Now that may sound like common sense, but a lot of what I'm going to be saying today really boils down to this very important principle, that people with behavioral health conditions are still people first and foremost and are deserving of respect and dignity as a result of that. How do you do that, though? How do you shift the system toward a more respectful, dignified stance for the people who use our services? One way is to disseminate the research on recovery that shows that people can, in fact, get better. These may be long-term, but they're not chronic diseases. They don't need to be. Recovery is possible, and staff need to know that. Staff need to know that behavioral health issues don't define who the people are who have them, and that recovery is not only possible, but it's common. Staff need to use first-person language to indicate that the person is more important than any diagnosis or behavioral health concerns. I grew up in Georgia, and the Georgia system has been very strong in its peer support, expanding and growing its peer support workforce. And I like to tell people that when I was in high school and started volunteering at the mental hospital in Atlanta, you would pick up a record and it would say, Joe is a 43-year-old CPS. And that would mean he's a chronic paranoid schizophrenic. And that's all you need to know about Joe. But now if you're in Georgia and you pick up a medical record and it says Joe is a CPS who is doing such and such, Joe is a certified peer specialist. And in that respect, we have come a long way, but we still have a ways to go. How people human rights are respected. Recovery is first and foremost a human rights movement, which was inspired by the independent living movement among people with physical disabilities and the African American and women's movements of the 60s, 70s. And staff need to be educated about the history of the mental health consumer survivor and addiction recovery advocacy movements. They should be made aware of how people with behavioral health conditions were treated as second class in the past and as less than human, and attend to the human rights dimension of recovery in their work both inside and outside of the behavioral health system. You can tell when this is happening when people being served and their families are held in high regard and treated accordingly. They are viewed as active agents in their own recoveries and members and full citizens of their communities. Staff know about and expect recovery. This is not only through the research I already mentioned, but more importantly, perhaps through the success stories of local people who've entered recovery and who are willing to be public about it and be role models for others. These should be public and commonplace. They should not be the exception, but should be more the norm. Staff could invite people back to share their recovery narratives from programs they've graduated from or left, to instill hope and offer encouragement. Staff need to view each person they serve as a unique individual who has their own hopes, dreams, and aspirations, and is worthy of being loved and capable of loving others, because that's what gives our lives meaning, whether you have a behavioral health condition or not. The basic message to be conveyed by staff should be people can recover. You can have a full and meaningful life. How may we help you? People in recovery have a voice in the system. Moving on to mention B. How are people receiving behavioral health services included in the design, delivery, and evaluation of care? So first of all, they should have a voice in the system. There should be visible, active involvement of persons in recovery on planning councils and boards and program and system level advocacy roles. They should be present in administrative and supervisory positions and have a strong voice in deciding on service and system objectives. The dictum of nothing about us without us, which was borrowed from the independent living movement of people with physical disabilities, should be honored in practice at all levels of the system. I think it's easier to understand that if you have had your own behavioral health condition or if you have a loved one who does. You want to play an active role in the care that you receive. You want to have an active role in the improvement of the services that other people will receive in the future. Recovery advocacy community is seen as a valuable ally. I've consulted to many states over my 30-year-plus career, and it's often the case that the recovery advocacy community was initially viewed as detractor, as a critic, as a loose cannon, as lots of unfavorable ways of thinking. But it's incumbent on a system of care to embrace the recovery advocacy community and to find ways to work together. So long-standing and established advocates should be invited to the table to honor and build on their previous efforts. Public venues should be offered for peer and family leaders to inspire others. Efforts are made to identify and cultivate additional leaders. We always use more leaders. Peer and family advocacy organizations are invited to collaborate in developing a shared platform for transformation. They have their own visions of how they would like to see the system move. Their views and recommendations are actively solicited and afforded substantial influence in relevant policy initiatives and grant applications to improve or add to services. So they're not approached at the last minute saying, please sign off on this to show that we had consumer or family involvement, but they're there at the very beginning. And input is sought from them, from service users and families. Input is sought using focus groups, surveys, town hall meetings. There are many ways of eliciting feedback and input. And ongoing mechanisms like those should be in place for eliciting and incorporating service user and family feedback through quality improvement initiatives, peer and family-based monitoring efforts, and evaluation activities. Peer supports are integrated. I think peer support is now present in all 50 states, but it's integrated to varying degrees in local communities as well as at state-level systems. And it's important not only that we train and hire peer staff, but that we integrate them well into services so that they can best provide what unique contributions they have to make. So efforts are devoted to training, hiring, supervision, and promotion of a growing cadre of peer staff, but also to preparing the non-peer staff workforce to welcome them, to support them in their important work. Moving on to Section C, how care is planned, delivered, and improved on a continuous basis. The focus of care is on building a healthy and self-determined life in the community. That's been one of the major shifts in attitude and in practice in the recovery movement, is going from being symptom-based and deficit-based to being strength-based and solution-based. Not just what's wrong with people, but what's strong about people, as someone in Georgia once said. So the system is oriented to strengthening service users' abilities to lead self-determined lives. The focus of care is on the whole person, integrating biological, cultural, spiritual, and personal dimensions. Terms such as social and community inclusion are common and are considered important to people's behavioral and overall health and well-being. Within this broad context, medications are used judiciously and in combination with psychosocial interventions, community supports, and self-care tools. Care is community-based and focused. It's been several decades now since the percentage of available mental health funds, it went from being disproportionately spent on hospital beds to now being proportionally spent, more appropriately we think, on community-based care. And that's where people belong, in the community. Services should be easy and flexible to access. People should not lose supports as their health improves. There's no wrong door, and the people at each door are respectful and responsive if they need to help people find resources or assistance in other parts of the system. And they provide guidance for how to navigate the system. And there's coordination and integration of care across services, programs, and agencies based on each individual's recovery plan. The integration of the care needs to happen through some formal mechanism, and we suggest an individual recovery plan plays that role. There are trauma-informed crisis alternatives. Restraint and seclusion continue to be practices that are they're restricted to emergency measures, but they continue to be used in our hospitals. That we need to try harder to help people earlier in the process before they get to states of such distress. Things like warm lines and peer staff respite programs are nice alternatives, and sort of step-down facilities as well. Staff need to be trained in de-escalation and trauma-informed approaches for avoiding the use of restraint and seclusion, and we need to be more committed, more determined in finding alternatives to these practices. Oops. Community life is encouraged. When interested, because we're not saying that we force people into having a life in their community, but that's what most people desire. And when they desire it, when they're interested, people are helped to obtain reasonable accommodations as needed and are assisted and supported in succeeding in school and work. They're encouraged to pursue careers that interest them. They're encouraged to go back to school if that's of interest. And hope is instilled. Maybe this should have been the first item, but hope is very important. Hope is instilled by having visible role models, by having recovery education, by encouraging people and setting positive frames. People are offered information and resources they need to understand and manage their concerns and their health. In Connecticut, many years ago, we adopted as our motto for our efforts to transform to a recovery-oriented system of care the Home Depot motto of "You can do it, we can help." We want to convey that message to people that they can do this thing called recovery, and we can help them acquire the tools, the skills, the supports they need to be successful. Care plans, that person-centered recovery plan I mentioned before. Each person is actively involved in developing his or her own individualized recovery plan. And that plan is based on their unique life goals. It's not only based on symptoms and impairments and struggles, but it's based on what kind of life the person wants to lead and what are the steps in between where the person is now and where the person wants to get to. Plan is, and it is not restricted to treatment, but also includes a broad array of interventions, action steps, supports, self-care strategies, natural supporters in the community, landlords, employers, other people who support this person in having the kind of life that he or she desires. Coercion is avoided. Coercion and involuntary interventions are avoided, and substitute decision makers are used only as necessary. Advance directives and other means are used to ensure that people continue to have a say in their lives and care even when in crisis situations. For those of you who are not familiar with psychiatric advance directives, they're an analogy to a living will. A person can complete a psychiatric advance directive depending on the state they live in. It may be called something different, which basically says, I know myself well, and I know that when I'm not doing well, these are my preferences for how other people should treat me, and these are the things that may need to be taken care of if I have to go to the hospital or the emergency department or to a higher level of care. We want to prevent crisis situations, but when they do inevitably occur, we want to be able to learn from them and plan better in the future to be more effective. There's been a lot of discussion because of our tragic shootings, mass shootings, about whether we need to be more coercive and use more involuntary interventions so that people with serious mental illnesses are not violent. but the data consistently shows that people with serious mental illnesses are only responsible for about 2% of gun violence in the country. The other 98% come from other sources. Access to trusting relationships is emphasized. There's been over 75 years of academic research on psychotherapy that has shown that the most important ingredient in effective psychotherapy is the relationship. Trusting relationships are key, not just in psychotherapy, but in all healthcare settings. So staff should place a core emphasis on the cultivation of trusting and helpful relationships. And continuity in relationships is given priority in considering the next stage in a person's care or recovery. We know how attached we might get to our own healthcare providers and how difficult transitions can be. The same is true, if not more so, for the people we serve. Trauma is addressed, so we not only try to prevent trauma from occurring, but we address it because we know it's there. Services and supports are sensitive to trauma, and trauma treatment and trauma-informed care are readily available. Families are involved. This, of course, for adults, this needs to be with the permission of the person of concern, needs to have say in what ways their family may be involved, but ideally, unless it's counterindicated, families should be informed and educated about recovery. Family support should be readily available. These conditions take a toll on families, not just individuals. People are encouraged to include their families in care planning and view them as supports in their long-term recovery journey. Outcomes are assessed. It was a lot easier, it's tragically so, in the old days when we didn't expect people to get better. We didn't really show much concern about outcomes, and treatment plans would basically say, continue as indicated or continue as previously established, or there was no sense that people were supposed to be getting better. Well, now we know that people can get better, and so we need to start looking at whether or not the services we provide help them to do so. So outcomes should be regularly assessed and used to measure the performance of the system. If people don't get better, it's not their fault or the fault of the system alone. It's also, if they don't get better, it's not the fault of the person or the family or the service providers alone, but the system also has a role to play. Systems can be more or less effective in promoting recovery, and systems need to take a look at themselves and see where they fall on that continuum. Useful feedback is given to staff, programs, agencies, and incentives are offered for improving outcomes when possible. Quality improvement and performance management results are used to improve quality of care. Leaders take strategic actions based on findings of performance measurement, performance monitoring, quality improvement, and outcomes monitoring activities in order to increase the quality and effectiveness of care. To go back to Section B, those efforts should always include stakeholders as well as providers and will be more effective to the degree to which they do so. Physical health is attended to. We're doing a much better job of this now since the 2006 or 7 report, which showed that people with serious mental illnesses die on average 25 years earlier than their non-ill peers. So there's been a significant focus on integrating primary care with behavioral health care. Again, we still have a long way to go. Staff need to be trained to address the physical health status and needs of service users through integrating and or coordinating primary care with behavioral health care and by promoting healthy lifestyles, including nutrition, exercise, and wellness. We understand better now how discrimination, poverty, unemployment affect people's physical health as well as their behavioral health. But we can't just throw up our hands and say those are social structures or social conditions or social determinants of health that we as practitioners have nothing to do with. We have to find ways to address them creatively and resourcefully. One example being that attention is paid to enhancing social support. We need to look and see if people have other people in their lives who care about them and who support them. People need to be offered opportunities and supports to develop friendships, romantic relationships, to belong to faith communities, to do the kinds of things, to go fishing, if that's their desire. But people need active social lives. They need other people in their lives, and they may need supports in order to do so. Similarly, staff pay attention to basic needs and social roles. Staff pay immediate focused attention to basic needs, including human rights, housing, income, healthcare, and transportation. And then staff, in a more advanced way, also need to pay attention to social roles. Does this person have an identity other than being a behavioral health client? There are roles like employee or employer, tenant, parent, student, congregant. People want to be something, and we could do a better job helping them to stretch and grow and try out new things. Another thing that we've become at least more aware of over the last 15 or so years, if we're not yet doing as good a job addressing it as we need to, are disparities. And health disparities need to be identified and addressed at the local as well as state level, and they need to be identified in collaboration with stakeholders. And then addressing them often involves developing culturally responsive interventions and getting culturally diverse and staff who are reflective of the people they serve. Staff ask for feedback. Everybody asks for feedback. Restaurants ask for feedback. Stores ask for feedback. Insurance companies ask for feedback. We need to be asking for feedback about how we're doing. We need to routinely ask individuals and family members for feedback about the care they use and ensure that they don't suffer repercussions for giving that feedback, that there's not backlash against people for raising concerns about inadequate or sufficient or disrespectful care. There's a focus on self-care. Recovery for some people is something they recover from entirely, but recovery for other people is something they learn to live with. Learning to live with, a behavioral health condition. And learning to live with a behavioral health condition requires self-care and learning how to take care of yourself, including tools that may be available. So the system has developed and offers education and training on resilience, recovery, and self-care strategies. There are trained parent and recovery educators who can teach people how to use the array of self-care tools available. And then there's the leadership issue. Transformation requires active and committed leadership, and it requires leaders who are engaged and action-oriented, people who don't believe that we've already done as much as we can do, but who set goals and want to pursue improvements in a consistent way. So leadership review and revise or replace key policy documents so that they promote recovery and social inclusion, that these are seen as important goals of care. New infrastructures developed to implement desired changes, so they modify care planning protocols, identify HR procedures that get in the way of hiring peer staff, etc. They have a broad vision of their system and understand that this needs to be changing at every level. Leadership needs a role model for staff. They need to be strength-based and encourage risk-taking. The mental health system, behavioral health system, has been very risk-averse for many years, and it requires a much more balanced view of when risks are reasonable, because people often cannot grow without taking some risks. So leadership initiates long-range strategic planning to identify and build on pockets of innovation using an inclusive, strength-based approach. Service users, families, direct care staff, and agency leaders are engaged in an inclusive process of identifying and building on system strengths, as well as identifying and addressing structural disincentives to change. Leadership, again, role models by emphasizing shared decision-making and collaboration. Systems offer highly individualized care based on person and family-centered planning. Infrastructure has been developed for use of advanced directives, which I described before, and other personal planning tools. Shared decision-making tools and decisional support are available. Shared decision-making needs to become the expectation rather than the outlier in practice. This may seem obvious, but if you want a recovery-oriented system of care, you need to train your workforce in recovery-oriented care. One unfortunate aspect of the recovery movement has been renaming things with the term recovery without really changing anything about the practice that goes on underneath the label. We need to do a better job there. The workforce needs to be trained in the application of resilience, recovery, social inclusion values and principles, and how they are manifest in clinical and rehabilitative practice and through the provision of person-centered, strength-based, trauma-informed, culturally competent care. The workforce also needs to be culturally responsive. We mentioned this when I was talking about disparities, but it goes beyond that, disparities. The workforce can be educated about the role of culture, race, ethnicity, sexual identity, and orientation, including their impact on patterns of help seeking, service utilization, care planning, self-care, and recovery. So that's the inventory, and those are the 30 items that, to my mind, have best captured so far the kind of work entailed in shifting from a symptom-based, de-integrated, if that's a word, or unintegrated, I suppose, system to one that's integrated, that serves people with co-occurring disorders when they have them in an integrated way, and which builds on strengths and maintains a vision of recovery. I think we have time. Yes, we have time for comments and questions. I said a lot in half an hour, I know, but I would be very interested in hearing from you about what you think and what questions or concerns you have. Justin asks, can I elaborate on the idea that leadership should encourage risk-taking? Sure. We have associated risk with mental illness, and I'm not sure why that is, because most bad things that happen in life have nothing to do with mental illness. People with mental illness pose no more risk of violence than people without mental illness, but they're victimized 14 times as much as people without mental illness. So if anything, we sort of have it backwards. But I think staff also, out of beneficence, don't want to sort of rock the boat if someone's stable or doing well enough. They don't want that person necessarily to take risks that would set them back. As a parent of 3 children, I can well understand that also. But there's no growth without risk, and people need to be helped in assessing the proportion of risk and the potential payoffs versus the potential downsides. Pat Deegan has written quite a bit about risk and recovery and how we need to not be at either end of the spectrum of being overly restrictive or overly permissive, but we need to help people think through when risks are present and when risks may be worth taking and what might happen if things should go bad. So in general, avoiding risk means that we're not encouraging people to try new things. Trying new things inevitably entails some risk. Anyone else? Oh, leadership should encourage risk, not just providers, but leadership should encourage risk. Yes, that is more complicated. People in positions of leadership can see their job as sort of keeping status quo and protecting systems from the onslaught of other factors, including budget cuts, which are inevitable these days at the state level. Or they can see their job as being a change agent. And I think if you're aspiring toward creating a recovery-oriented system of care, there's no way to do that by maintaining the status quo. You have to see that it really requires redesign from the bottom up, and that's going to require risk, political risk. You have to be smart about that, though, because if you go at it recklessly and too quickly, you might end up losing your job, and then you're not in a position to help bring about change. So it needs to be thoughtful, but there needs to be an understanding that there will be risk involved in changing how things are done, but the longer-term payoff needs to justify the risks that are taken. So it's, in some ways, it's a lot like being a clinician with a patient you're hoping to support their growth. You're hoping to support the growth of the system, and things might go badly, but things also won't get better unless you try new things. If you keep doing things the same old way, you get the same old results. Any other questions or comments? How to help each unique individual learn and cultivate a good community life. Well, that's hitting the nail on the head. How to do that? Through relationships primarily, through getting to know the person, by treating the person with dignity and respect, by engaging them in a relationship where you offer hope that things can get better, and over time, and it does require time, to introduce new activities or new interests or new goals and aspirations. So by asking somebody, what would an ideal community life look like for you? And then you can step back and say, and how do we get there from here? But people have their own desires. I worked with a man diagnosed with psychosis many years ago when I was in training. And when I was persistent in asking him this question, what would you like to do? What would make things better? He finally came up with the idea of having a cheese omelet that he made for himself. That was something that would really improve the quality of his life. He loved cheese omelets, but he loved them to be made a certain way, where at the last minute they're put under the broiler so the cheese melts and leaves a crust. So it took us about 4 months working together with his mother to get her to allow him to do this. She was worried he would burn the house down. Talk about risks. She was worried that he would leave the stove or the broiler on and the house would burn down. So we got her to agree to allow him access to the kitchen, and that she would come in when he was done to make sure everything was turned off. That's what made his life better. Other people will find other things. I know a young man with a mental health condition in Stockholm, for example, who discovered bowling, and he became an amateur bowler, and he won the Amateur Bowler of the Year for Sweden because he fell in love with bowling so much. And that, as he said, he became a bowler. He was no longer a mental patient, but he was now a bowler. It's through engagement in a trusting relationship where you get to know the person and you get to know what would bring them alive. I hope that's sufficient answer. We could talk about that particular question for a long time. And not to do a plug for myself, but when I get to the third of this series on can clinical care be recovery-oriented, I will talk a lot about that very question. Because that's what recovery-oriented clinical care looks like. Can you comment on, Justin asks, can you comment on innovative recovery-oriented ways to incorporate families into care, apart from providing them with psychoeducation or holding family support groups? Another great question. How can families be involved in a person's, well, I would say that families don't necessarily need to be involved in the person's care as much as in the person's recovery. it's up to the adult focus the degree to which they want their family members involved in their care. However, they're going to be involved in their lives one way or the other. And the question is how they can be involved in the person's life in a supportive, positive way. And that goes back to the question we were just discussing about each individual. It's unique, and there may be ways, for example, with the cheese omelet, the way that this person's mother could be supportive of his recovery was to allow him access to her kitchen, reassure him that he could spend the few extra pennies that it would take to rev up the broiler so he could make the omelet in the way he wanted, and then to enjoy with him his success in making his own cheese omelet. Families can support people in getting involved in social activities of their choice. If they want to go to movies, you go with them to a movie. If they want to go to church or a mosque or a synagogue, you offer to go with them, providing instrumental support as well as emotional support. I know most families try to do this, and it's something that we as clinicians have not paid a whole lot of attention to. So what we've done have been family support groups and psychoeducation. We haven't really looked at it on an individual basis as much, unless the person's in family therapy. But there are creative ways that family members can instill hope, help the person imagine a better life, and then help them take the steps they need to get there. Which is going to depend on the individual aspirations and goals of the person. Families must have some level of comfort with the issue of risk as well, because they see it as having a lot to lose should things go badly. But that shouldn't keep them from trying out new things with their loved one. Any feedback? It doesn't just have to be questions. What's my opinion on the role of technology as a tool to mediate some of these processes? There's a significant amount of work going on right now around the potential use of technologies in promoting recovery, both in terms of relapse prevention / self-care, so technology that will help the person monitor their bodily responses and states and will alert them to potential danger coming, but also just through things like social media, telephone, peer support. There's lots of ways in which technology can be very useful, especially for people in rural areas, or people who are isolative, who are afraid of getting out of their rooms. There's a lot of ways in which technology can be turned to good use. These are all being explored. There's no research, as far as I know, that really shows that they work, but there's no reason to think they wouldn't. Being of the age that I am, I'm a little leery of technological solutions to human problems, but I think in this case they can be useful tools. Again, any feedback? I have 3 more of these in this series to do, so if there are things you would particularly be interested in hearing about or concerns you have, I would be very interested to know. Cultural disparities. How to address cultural disparities. The first and most effective way to address cultural disparities is to hire people from the cultures that the people come from that you're serving. That's not always so easy to do. in that case, if there are no such people around or not a sufficient number of them, then getting familiar with the values and worldview of the culture that the people come from that you're trying to address would be very important. We've run into this in terms of trying to spread the good word of recovery in Asia, where the idea of a person-centered care plan or a person-centered recovery plan doesn't make as much sense because it's much more of a family issue than a personal issue. And individuals are not necessarily encouraged to make their own decisions whether they have a behavioral health condition or not. So learning about that and learning that someone coming from a different culture than your own is going to have different values and a different worldview can be essential to offering care that's actually useful to them. Justin would welcome any discussion or comments on how psychiatrists can shift from being simply the ones to assess symptoms and diagnose and offer medication to be more actively involved in the recovery process. I think there are a lot of ways that psychiatrists can be actively involved in the recovery process. The question is whether they will be reimbursed by Medicaid or private insurance to do so. I think the psychiatrist's role has become very narrow, in part because of the hope for a biological cure, but also in part because of our healthcare system. So there are countries in the world where psychiatrists still do psychotherapy. There are countries in the world where psychiatrists lead interdisciplinary teams that provide therapeutic interventions. There are lots of ways a psychiatrist can be promoting recovery. Not that medication is not an important part of that. Medication is certainly an important part of that for many people. I've taken medication myself for 22 years, and I rely on my psychiatrist to be very knowledgeable about the ins and outs of the medications I take. But there are other things as well. Psychiatrists are also in a good position to be the link between the primary care sector and the behavioral health care sector since they have medical training. But it's really a healthcare reform question more than a disciplinary question as to what psychiatrists will be allowed to do. Regardless of that, they should certainly be a part of the person-centered recovery planning process and should have an important role to play in that process. Well, Vanessa, if there are no further questions or comments, I think we can wrap it up and we can offer people the opportunity to download both the inventory and the SAMHSA guidebook on recovery-oriented systems of care.
Yes, hi everyone. We do, like Larry said, we do have the 3 other parts of this 4-part series. And you can click on register and register under Principles and Practices of Recovery-Oriented Care. That link should take you to the 4 parts of the series. And if you go on our website as well, I will post that link here on the chats and question box. Our recorded webinar along with the resources will be posted here as well.